Hello and welcome. Today we'll be discussing a crucial, yet often overlooked, aspect of immunosuppressant therapy, calcineurin inhibitor toxicity, specifically focusing on its impact on the urinary system. Calcineurin inhibitors, or CNAs, like cyclosporin and tacrolimus, are vital medications used to prevent organ rejection after transplantation and manage certain autoimmune diseases. However, their therapeutic window is narrow. CNI toxicity primarily arises from excessive drug levels in the blood. This can happen due to individual differences in drug metabolism, drug interactions, or simply exceeding the prescribed dosage. Factors such as impaired liver function, which affects CNI metabolism, and co-administration of medications that inhibit or induce the cytochrome P4050 enzyme system can significantly alter CNI levels, increasing the risk of toxicity. The pathophysiology of CNI-induced nephrotoxicity is complex and involves several mechanisms. Primarily, CNV is vasoconstriction of the afferent arterioles in the kidney, reducing renal blood flow and glomerular filtration rate, leading to acute kidney injury. Chronically, CNIs induce structural changes in the kidney, including tubular atrophy, interstitial fibrosis, and arteriolar hyalinosis. Calcineurin, as its name implies, normally activates T cells. By inhibiting calcineurin, we also impact the renin-angiotensin-aldosterone system RIASE, impacting sodium retention and blood pressure. This cascade leads to long-term kidney damage and ultimately affects the urinary system's ability to effectively filter waste and maintain fluid balance. While precise epidemiological data are challenging to obtain due to the widespread use of CNIs in transplant recipients and autoimmune disease patients, the incidence of CNI-induced nephrotoxicity is significant. It's estimated that a substantial proportion of transplant recipients on long-term CNI therapy will experience some degree of chronic kidney dysfunction. Furthermore, certain patient populations, such as those with pre-existing kidney disease or hypertension, are at higher risk of developing CNI-related kidney problems. The signs and symptoms of CNI toxicity affecting the urinary system can be subtle, especially in the early stages. Common indicators include a rise in serum creatinine and blood urea nitrogen (BUN) levels, reflecting a decline in kidney function. Patients may experience decreased urine output, fluid retention leading to edema, and elevated blood pressure. In more advanced cases, symptoms of chronic kidney disease, such as fatigue, nausea, loss of appetite, and electrolyte imbalances, may become apparent. It's important to remember that many of these symptoms can overlap with other conditions, making early detection challenging. Diagnosis of CNI nephrotoxicity relies on a combination of clinical assessment, laboratory testing, and sometimes kidney biopsy. Serial monitoring of serum creatinine and CNITR levels is crucial. A rise in creatinine coupled with high CNI levels should raise suspicion. Measuring urine protein levels can also help assess the extent of kidney damage. If the diagnosis remains uncertain, a kidney biopsy may be necessary to evaluate the histological changes characteristic of CNI toxicity, such as tubular atrophy and interstitial fibrosis. It is essential to rule out other causes of kidney dysfunction before attributing it to CNI toxicity. CNI toxicity in the urinary system doesn't have distinct classifications beyond acute versus chronic forms, mainly differentiated by the timeline of symptom onset and the extent of structural damage to the kidney. Acute toxicity usually manifests as a rapid decline in kidney function associated with high CNI levels, while chronic toxicity develops gradually over time, leading to irreversible kidney damage. The cornerstone of treatment and management of CNI toxicity is dose reduction or discontinuation of the offending agent, guided by therapeutic drug monitoring. Converting to an alternative immunosuppressant regimen, such as an mTOR inhibitor, may be considered. Supportive care includes controlling blood pressure, managing fluid balance, and correcting electrolyte imbalances. In cases of severe acute kidney injury, temporary dialysis may be required. Angiotensin-converting enzyme inhibitors (ACEs) or angiotensin receptor blockers (ARBs) can be used to help control blood pressure and may have a renoprotective effect. Prevention is paramount in minimizing the risk of CNI toxicity. Careful attention to dosing guidelines, regular monitoring of CNI levels, and vigilance for potential drug interactions are essential. Optimizing patient hydration, avoiding nephrotoxic medications, and closely monitoring kidney function are crucial steps in preventing CNI-induced kidney damage. Educating patients about the potential risks and the importance of adherence to their medication regimen is also vital. The prognosis for patients with CNI-induced nephrotoxicity varies depending on the severity and duration of the toxicity, as well as the patient's overall health. Early detection and prompt intervention can often reverse or stabilize kidney function. However, chronic toxicity can lead to progressive kidney damage and ultimately end-stage renal disease requiring dialysis or kidney transplantation. Recent research focuses on developing more targeted immunosuppressants with fewer nephrotoxic effects. Furthermore, studies are exploring the potential of biomarkers to predict and detect CI toxicity earlier, allowing for more timely intervention. Ongoing research into novel rhinoprotective strategies aims to mitigate the long-term consequences of CNI exposure.